Good afternoon and a warm welcome to this webinar on the theme of how to set up a PGT programme. I'm Emily Austin, Managing Director of CooperSurgical Fertility UK and Ireland, and it's a pleasure to have you join us today. It's great to see so many of you. We're very lucky today to have multiple speakers with us on this webinar, so I'm going to crack on and get started with introducing everyone. First up, it's a return for one of our speakers, a very big welcome again to Dr. Claire Moran. Claire is the Laboratory Manager of Repromed Dublin. She graduated from University College Dublin with a PhD in pharmacology. She began her embryology training in 2006 at the Liverpool Women's Hospital. After her return to Ireland, she gained considerable experience in the field of reproductive medicine across some of the leading fertility clinics in Ireland. Claire has a keen interest in research and development in the area of reproductive medicine. We're also very pleased to have Rahul Naik joining us today. Rahul works at Herts and Essex Fertility Centre and comes with a wealth of international experience in the field of fertility, having also worked in the Middle East, India and Singapore before settling in the UK, where he's worked in Southampton and London, where he set up a brand new facility with a fully functional IVF laboratory in Harley Street. Rahul did his specialisation in clinical embryology at the University of Leeds. Rahul's interests are in innovative and emerging technologies for assisted reproduction. We also have Davina Hume joining us today. Davina began her career in embryology in 2001 after graduating from Sheffield University with a degree in anatomy and cell biology. In 2005, she completed the ACE certificate in clinical embryology, and this was followed by state registration. Davina joined Jessup Fertility in 2015 and was soon appointed into a senior embryology role. Davina has specific interests in training and education, time-lapse incubation and pre-implantation genetic testing of embryos. Davina is an associate lecturer with the University of Sheffield as part of the MSc course in reproductive sciences. When joining Jessup Fertility, Davina had a desire to use her prior experience in embryo biopsy and PGT to train other embryologists and set up a successful PGT service within the clinic, which is fabulous. We'll hear more about this experience shortly. We also have joining us today our very own Zuza Bieneska. Zuza joined CooperSurgical 3 years ago as Genomics Customer Support Team Manager. Before that, Zuza spent over 6 years working for Bluenome and the Reproductive and Genetic Health branch of Illumina as a technical and product support specialist, as well as a field application specialist. Zuza has a PhD in molecular biology from the Max Planck Institute in Germany. We also have, I said it was quite a lot, Dr. Tony Gordon. Tony is a PhD molecular cytogeneticist with over 20 years experience of molecular diagnostics, having worked for, amongst other organisations, the Institute of Cancer Research, Bluenome, Illumina and Genesis Genetics, who were acquired by CooperSurgical. Tony is the Director of Clinical Operations for the UK Labs and the Global Vice President for Business Development for Genomics. Tony undertakes research in the PGT field, publishing papers, conducting scientific trials, and working to bring scientific developments and innovation to the PGT field, including our new offerings, PGT AI 2.0 and 2.0 Plus. And we also have joining us today Dr. Steve Troupe. Steve has worked in the field of human clinical embryology for nearly 35 years, starting in Manchester, where he completed a PhD in male infertility and the acrosome reaction. Before his recent role as the Scientific Director of EV UK, Steve was the Scientific Director of Liverpool Women's Hospital, Hewitt Fertility Centre, one of the UK's largest providers of assisted conception. Steve has been both Chair and President of the UK's Association of Clinical Embryologists and a founder member of the newly formed Association of Reproductive and Clinical Scientists, and a Scientific Inspector as well for the advisor for the UK regulator, the HFEA. Steve now works independently as a consultant reproductive scientist based in the UK. So we will start today with a couple of short presentations, and then we will ask our panel to recount their experience of setting up a PGT programme. Practically, how did they achieve this? What were the obstacles and how did they overcome them? We have a few international delegates today, which is wonderful. You're most very welcome to join us. Wherever you may be based around the world, our panel members are from the UK and Ireland, so any references we make to regulation will have the UK and Ireland in mind. If you have questions during the presentations, and whilst the panel are discussing their experiences, please enter them into the chat box. We have 60 minutes today, so there'll be plenty of time at the end to answer your questions. Thank you very much. Steve, I'll now hand over to you. Steve. Can you unmute, please?
Yeah, my apologies. I've lost the video control. Okay, I'll do this without my face on the screen. My apologies. So thanks, Emily, for asking me to take part in this webinar, and also thanks to those of you that have responded to the poll, the results of which you can see on the screen now. It is interesting. There seems to be quite a broad range of reasons why people have or perceive obstacles in terms of setting up a PGT program. Perhaps most interestingly are that almost nearly half of the respondents have said that there are other reasons that weren't given as options there, and I think that'll be very interesting to pick that up in the Q&A session at the end. So I'd like to, just by way of introduction, show 3 or 4 quick slides. Firstly, the slide on the screen now shows that nearly half of all centres in the UK now offer pre-implantation genetic testing, certainly according to the information on their websites. So I guess this means that in the UK, at least, a large number of fertility specialists see a benefit to the use of pre-implantation genetic testing. But we are still faced with a challenge in respect of Pgt pre-implantation genetic testing for aneuploidy, and that is that there is still not very many very high quality randomized controlled trials examining the benefits or otherwise of PGTA. And for this reason, i.e. the lack of very high quality evidence, the HFEA still rates PGTA as red. So I think we need to do 2 things. Firstly, we need, if at all possible, I think to try and fill the research gap and to conduct appropriately designed and powered studies. But the simple reality of that is that these studies are, as many of you will know, are extremely challenging to perform, requiring thousands of patients in each arm, often a multi-centre approach because a lot of centres are quite small, and not least, they require very high levels of funding, often running into millions of pounds. So I think the second thing that we should do, therefore, is to look at all of the evidence that's currently available, to recognise its weaknesses where they might exist, and to take a balanced view of the current situation. And I think if you do that, certainly in my opinion, it very much looks as though PGTA is likely to be effective in improving treatment outcome, particularly in older patients. And one example of this, which I'd like to bring to your attention, some of you I'm sure will have seen this, I thought this was extremely interesting, and it was work presented by Professor Darren Griffin at the Fertility 2021 conference last month. And through a Freedom of Information request to the HFEA, Professor Griffin and his team were able to analyse a number of treatment outcomes relating to PGTA. And you can see on the slide that here, in that nearly 2,500 PGTA cycles, the live birth rate per embryo transfer was higher when PGTA was performed than not. And again, interestingly, all of these differences apparently were statistically significant, so that advantage of PGTA even persisted in the younger patient group, in the patients under 35. So surely these data point towards something good about PGTA. Of course, there is a lot that needs to be done to set up and to run a PGT program. And I'm now going to hand over to the rest of the panel and let them tell you about their experiences. So thank you for listening, and I think we're handing over to Zuza now. Thanks again.
Thank you very much, Steve and Emily. Good afternoon, everyone. So, in your journey of starting a Pgt laboratory, you will be introduced to the customer support team. This usually happens by the introduction of your account manager. This usually happens when we have SLA in place, when you've got your HFEA license in place. Or you are just about to get those. But nothing stops us to also help you with your during your journey to open a Pgt testing laboratory. So who are we? So this is our genomics support team. We consist of the sort of two sub-teams, but we work with each other very closely. Genomic support team is the team that is usually responding to any general inquiries. If you've got any technical questions about the platforms, or if you've got any questions about the reports issued, we are helping out with the logistics of getting those cases for testing to our laboratory. We are in between testing laboratory, in between the GC team and yourselves. So general genomic inquiries, they are answered by Reem, myself, and Michael. Then we've got another sub-team, and this is Pgt Case Coordination Team. So some of the cases, Pgtm, Pgtsr cases, they require to receive medical documentation prior to the case acceptance. And what our coordinator will do, she will make sure that the right paperwork is requested and reviewed. So she is in between laboratory, she's in between genetic counseling team, and she will make sure that you are getting updates about the case enrollment or case optimization. So what you will need as well is to have the biopsy kits when you want to send the samples for testing to us. To order the biopsy kits, this is quite easy and straightforward process. All you have to do is to contact your customer service team. We are able to provide you with the biopsy kits and also polystyrene boxes and cold blocks. They are used for shipping the cases back to us. This is a standard next day delivery, though please allow a couple of additional days to get the order safely back to your clinic. The kits inside will contain the plastic rack. It will also contain tubes and corresponding buffers. And there is also, of course, the biopsy buffer for washing and tubing. Please check the expiry date that is on the label. Tubing validation. So this is the sort of voluntary exercise from our side, but this is something that we strongly encourage customers to perform. So during the validation testing, what we are looking to do is to see if you understand our tubing protocol. By all means, it's not complicated, but it's always better to practice on the embryos that you've got for this, rather than do it with the clinical biopsies. So we are testing our tubing protocol, but we are also testing the logistic of the case, of getting the case back to us. So we would be practicing the courier route, if the packing and receiving those cases, if everything is going smoothly. So during tubing validations, we would be only performing the very first step in the sample processing. So we'll be only getting the DNA that is in those couple of cells that you biopsy. We will be amplifying this, and we'll be sending you a very simple report back to your clinic stating if the sample is successfully amplified or not. Of course, every case will need to come to us with the specific paperwork. We try to keep it as simple as possible. There are 2 forms that will be needed to send the case to us. One of them is the test requisition form, and one of them is the biopsy form to be sent together with samples. There is one additional form. This form is only for Pgtm and for Pgt-SR cases. When it comes to the acceptance of the Pgt cases in our laboratory, this is for Pgta cases, the process is quite straightforward. So all what we really need to receive is the test requisition form, ideally prior to sample arrival, and then together with the samples biopsy form. For Pgtm and for Pgt-SR cases, there is the case review and approval process in place before we can actually accept biopsies in our testing laboratory. All Pgt reports are reported within 2 weeks. Once the Pgt report is issued, it will be password protected with the unique password that will be provided to you at the very beginning of our collaboration. And email report will be sent back to you to the email address that would be given by your clinic. If there are any questions about the results or reports, we kindly ask to send them back to our team, and we can answer quite a lot of those questions. If not, we'll seek the expertise from our lab team or from our genetic counseling team. I forgot to mention at the very beginning that for every new customer, we always offer an onboarding call. So during onboarding call, we spend around an hour when we discuss all our paperwork that is needed for the cases. We talk a bit more about how to enroll Pgtm case with us or how to enroll Pgt-SR case with us. We are talking more about the tubing validations and about the case logistics, because this really depends also where your laboratory is located. By all means, if you've got any questions, you can also ask them ahead of your onboarding call, and those are our 2 email addresses. Thank you very much. And over to you, Emily.
Thank you, Zuza. Thank you very much to Steve and Zuza for their Thank you very much to Steve and Zuza for their presentations. We'll now pass the baton to our guest panel members today to talk through their experiences of setting up a PGT programme, what you need to consider, what they needed to do practically to get a programme up and running, what training they needed to organise, and what obstacles did they encounter and how did they get around these. So first up, we'll go to Claire. Hi, Claire.
Hi, Emily. Hi, everyone. Thank you so much for having me here today. So I suppose I'll make a start. We are quite new to the PGT process in that we obtained our license in late 2019. So we're based in Ireland, first of all. So our license was authorized by the HPRA. So we got our license in 2019 and we began some cases at the start of 2020. So we were about a year into the process now at this stage. So I'll take you through it from the start in terms of what we needed in order to get our license. The first thing, I suppose, is why did we set up the program? And from our side, it was largely patient driven in that, I guess, as Steve said, 50% of clinics in the UK have a PGT program. The same applies in Ireland in that more and more clinics have their own PGT program now. And it's getting to the point where if you don't have a PGT program, you will lose patients to that. So we decided to set it up, and it's a considerable amount of work, I will be honest, to set it up, and you need a complete buy-in from the whole clinic. It can't just be lab-led, which sometimes things happen to be. But what we did was we set up a Pgt Coordination Team. So we had one person from the medical department, an embryologist, an administrator, a nurse, and also quality. And we all worked together to, first of all, outline what are our individual responsibilities. So the lab part is quite obvious in that we're the ones actually doing the biopsy, but there's a huge amount of work that has to happen before then. So we need to make sure that with our patient onboarding, that the patients are appropriately screened and counseled and know the limitations of this technique before they start. And then the nurses are their main support network through the initial phases. So they need to have a really good understanding of the process before we get started. So then that was our initial step, was to set up that team within the clinic. And then, of course, we had to get into the actual practicalities of change control and applying for a license. And I don't know if it's a little bit different in the UK, but in Ireland, you must have all your validation done and complete before you actually get your license. So we spent a lot of time going through the validation on that. So the first thing, I guess, is to, before you even start your validation, you need to look and see, what do you need to do this? And the most obvious thing is, do you need new equipment? For us, we did, because we didn't actively do assisted hatching, so we needed to purchase a laser. So again, there's a whole, it involves finance department, again, involves validation. So that's a whole project nearly on its own to get a laser, a freezer, to hold the samples, and we also purchased a mini centrifuge as well, just to spin the samples after tubing. So there's a little bit of pre-workup required before you even start your validation process. And then when it comes to the process validation, I suppose the trickiest of all are the lab aspects of it, because there's so many parts involved. So first of all, you have to validate your biopsy process. So in order to do that, well, in Ireland, certainly in our case, we don't create embryos for research or training. So we rely on patients to donate their embryos to us for training and development of the lab. So these would be embryos that the patient no longer wants, that might have been in storage for a long time, or they would be embryos which are deemed to be unsuitable for vitrification. So straight away, sometimes you have a little setback there, in that you're practicing your biopsy on embryos that are deemed to be very poor quality. So I think that needs to come into your validation process as well. And we took that into account, that, in our survival rates initially, that, there's certainly an embryo factor there if the embryo was graded as not suitable for freezing. We were lucky in that we were able to hire an embryologist that had biopsy experience. So that really helped us out to get started. But I think 3 or 4 of our staff now have gone on the biopsy training courses with Cooper Genomics, and they have been fantastic in gaining confidence and, just getting biopsy practice with the experts there on hand to ask any questions. The next process validation is the tubing validation, which Susa briefly mentioned. We did avail of all of the help and support from Cooper Genomics to get our program validated. And so each embryologist sent 20 samples, or tubed 20 samples with the corresponding blanks to Cooper Genomics, and we got those amplified, and that's how we validated our tubing process. Our vitrification validation, that was already validated, but again, we had to validate the vitrification of biopsied embryos. So for all of our training embryos, we vitrified those, and then we subsequently thawed them out and determined our survival rates on those. The next process validation is your shipment validation. Again, Cooper Genomics have a really good system in place for this, because they provide you with the documentation for the shipment validation, which is fantastic. Particularly since we're in Ireland and we're shipping to London, it's an overnight shipment. And so that was done concurrently with our tubing validation as well. So all of our tubing validations arrived in London safely, and the amplification was fine on all of them. The other thing to consider is your contamination levels. So you really want to, for those initial samples that you're testing, is to check your blanks and your negative controls to make sure that you have no contamination, a background contamination for any reason in your lab. So I suppose they're all of the things that you have to work through. And we presented these to the HPRA, and luckily we were successful in getting our license. But it is quite a considerable amount of work, and you do need the support from the other members of the clinic as well in order to get it through. Other things that we did to make, after getting our license, to make the process efficient in your lab, you need to think about that as well. I think it's important to consider how this is going to impact on your day-to-day workload in the lab. And from our side, we decided that we would only do biopsy collections on Wednesday, Thursday, and Friday each week. So we put all our patients on the contraceptive pill beforehand, and that means that all our biopsies take place during the week. So I suppose that works for us, but it is something to consider. You know, do you want to do biopsies at the weekends, and have you got the staff available to do that? So there's lots to consider. I'm just trying to think, if there's anything else. I suppose the supports that we use and we really rely on in terms of the background supports are the consenting platform, which is Engaged MD, and that is provided again by Cooper Genomics. And that is a platform of fertility videos and a little exam for the patient. So it teaches them about the biopsy process, the tubing process, you know, the background to it, and the risks and limitations of the process. And what I really like about that is that the patient can view those videos at home. They answer a series of questions afterwards. So we can identify which patients have understood the process, and then if there's any difficulties, we can contact those patients again and make sure that they fully understand the process before they embark on the actual cycle. And the nice thing about that as well is that the paperwork comes from Engaged MD, so that initial test request form can be generated within Engaged MD. So we really like that in our clinic, because there's a full traceability from the patient to that initial paperwork, and a full understanding gained by the patient. The other thing that really has helped us in running the program and in making it so successful is the access to genetic counselling, and that is provided by Cooper Genomics. In Ireland, it's extremely difficult to access a genetic counsellor. So the fact that we have almost immediate access to genetic counsellors for our patients is absolutely fantastic for us, and is a real plus for our program, in that we refer most patients that get a mosaic embryo, we like them to have genetic counselling before we transfer. So, you know, if everything goes well, obviously patients don't need the genetic counselling, but it's fantastic to know that it's there, and it's so accessible for us when we need it. So I think that is a very quick overview of our program setup, and I'm happy to answer any questions that you have at the end.
Wonderful. Thank you very much for that, Claire. Please do keep those questions coming in. We've had a few already, but please put in more for our panelists. And we'll hand over to Davina now to hear about Davina's experience of setting up a PGT program at Sheffield. Thank you, Davina.
Thanks, Emily. Good afternoon, everyone. So our experience is a little bit different to Claire's. So she did cover most of the things that we went through, but there were some differences being in an NHS clinic. We gained our license in 2018 and did our first cases of PGTA in 2019. And we decided to offer the service just because we'd identified patients where we thought they may benefit from PGTA, and we wanted to expand our service and be able to offer that to our patients. But we were in a lucky position because we already had a well-established Pgtm program. So we're a satellite clinic at the moment with Guy's Hospital in London. So we already had a team established here as part of that satellite service for Pgtm. So we had a designated clinical lead, a nurse, and we have strong links with the genetic department and the genetic counsellors within the hospital trust. And so that side of things was already established here for us. So that part of it was much easier. And I'd already experienced biopsy and embryos from a previous clinic, so I was able to already do embryo biopsy. So we can't treat at the moment our own Pgtm patients because we don't have the NHS contract. So our patients do go to Guy's still. So in the future, we're hoping that we will get that contract and be able to treat our patients here. So at the moment, we just treat PGTA patients and also Pgtm patients who are self-funding. So their fundings run out with the NHS, and then they can come to us for treatment. For us, I would say as an NHS clinic, the hardest part was getting approval from the trust to provide this as a service. And to be able to do that, we had to write an extensive business case that had to be presented to the NHS management. That was quite complex and lengthy, and also obviously it's something that the people you're presenting to don't understand what Pgt is, so you have to make them aware of what it is and try and explain it. So it was quite difficult in some aspects. And then we also had to work with procurement as well, because we, again, like Claire, we had to purchase equipment. So we had to purchase a laser, a mini centrifuge, and also, so all those things went out to tender. So we tried different lasers. We had to look into different genetics providers, so that we'd looked at all the costs, what they offered, and compared them before the procurement department agreed with us on what we wanted. So that part of it was quite lengthy, and probably was a good year before we actually got the license. The things that we controlled, like writing the SOPs and the patient information, was much easier. The things that we were under the control of was much easier. So in terms of biopsy training, we made the decision to train. Well, I was already trained, and we trained a further 2 embryologists initially. So that gave us 3 of us, mainly because we didn't think we were going to have many cases to start with. And obviously, as a practitioner, you need to keep your competency. And so therefore, we felt that having 3 would cover, people's annual leave, and it would give us the option of having a buddy. So when we do a biopsy, we always have a second person buddying with us. Because there's so much witnessing that has to happen, and that's so important at every step of the biopsy process and tubing, we felt that it was easier to have somebody just buddy with you to be able to do that at the time. So we trained 3 practitioners initially. So there was some in-house training because obviously I'd done that before, but we did utilize the 2-day biopsy training course from Cooper Genomics, and that was invaluable. And I actually attended it just as a refresher, just in case there was any new techniques that were happening that I wasn't aware of. And so that was really useful to have expertise there and to be able to practice in that environment. We also had other independent trainers come into the clinic to look at our setup, to make sure there was anything they could pick up on that we may need. And obviously we did email global support a lot, Zuza's team, for advice along the way, which was also really invaluable. So the training was happening at the same time as we're writing our protocols and policies. Obviously, an important thing is to agree your policy with your genetics team. What is your policy on what embryos you're going to transfer and what you would consider, what stimulation protocol you're going to use. We're the same. We try to avoid biopsies on weekends because there's only 3 of us trained, and hope it would be a strain at the weekend. We do have a normal service here on a Saturday, so we wouldn't be able to do the biopsying as well. So again, we put our patients on the pill so we can control that a little bit better. And then obviously when you come to applying for your biopsy, your variation of license to be able to offer PGT as a clinic, you need all your documents ready. So everything from your SOPs, your patient information, all the training records, how you've validated your biopsy practitioners and your processes, what your consent procedure will be, and a summary of what KPIs you're going to look at going forward as to how successful your program is. So as long as all of that is ready for the application to the HFEA, which is done on the portal, then that should run smoothly. If everything is in place and you have all those things, then that process shouldn't be too difficult. It is filling in quite a lengthy form, but if everything's in place, then that should be okay. In terms of choosing a genetics provider, we we obviously chose Cooper Genomics because of their experience and also the support that they offered. For us, it was really important to have customer support. It was a new service for Jessup Fertility, and so we just wanted the reassurance of, you know, the expertise that they had in helping us make sure that we were setting up the program to the best it could be, and that we were doing, you know, the biopsy process and the tubing and sending the cells all ran smoothly. And we did use them for the tubing validation. So all of us that were training to do biopsy did send tubed samples to Cooper Genomics for validation. A little bit different to Claire's clinic, we were a bit luckier in that we can use embryos that are in a fresh cycle that are not suitable to freeze, so they tended to be the poorer quality embryos. But we also used quite a lot of frozen embryos, so they may be reaching their 10-year expiry, or the patients have completed their family and didn't want to use them, and they would donate them kindly for training. And those embryos are invaluable because they are good quality embryos, because that's why we chose to freeze them in the first place. So you know, those embryos were really, you know, good to use in terms of looking at your survival and the biopsies that you could get from them. We decided that we would do, so you also, as part of your policy, you need to decide how many embryos is a good number to do in terms of biopsy practice and validation. We decided on at least 20 to 30 embryos. They are precious training embryos, and there were 3 of us, you know, wanting to use them. So that was our cutoff, with a 90% survival post-biopsy, and also we looked for re-expansion. We didn't look at overnight survival because the embryos, you know, the fresh ones tended to be poorer quality. So we tended to go for survival post-biopsy and re-expansion. And then also a 90% amplification rate with the cells that we sent to Cooper Genomics, and a very low contamination rate. And you know, we were aware that some biopsy practitioners are more confident earlier on than others. So if, you know, 30 embryos wasn't enough to be confident or to reach that 90% survival, then we would just keep biopsying until that practitioner was, you know, was happy to continue with clinical cases. And then we did a competency assessment where you watch someone doing a biopsy, make sure that they follow protocol, and then that's signed off by the PR before they do clinical cases. We also decided that because we didn't have many clinical cases initially, that we would split the cases. So 2 biopsy practitioners, so them and their buddy, would do a few of the embryos, because you know, we wanted to keep up competency in those initial stages. Other things to mention. Trying to think. I think that's covered most things that I think are relevant.
Oh, wonderful.
That's all right.
That's super. Thank you very much for that, Davina.
Thank you.
And next up we have Rahul. And Rahul, you're in a slightly different situation in that you're partway through setting up a PGT program. So perhaps you can tell us about your experience so far and where you're on the process and what your next steps are. Thank you, Rahul.
Thank you, Emily, for inviting me on this panel. And thank you to Hearts and Sex for allowing me to speak here. So, as you said, we are in a bit of a different situation wherein we haven't applied for the application of PGTA with the HFEA. And just because there have been a process wherein we need to get things in place, including instrumentation, including colleagues on board, and then acceptance that we would be happy to provide the service. As you said, there are various barriers wherein we need to cross, and we reach that eventually. So first and foremost, I'd say, why did we as a clinic agree to perform PGTA service? And that's, I would say, it's been, as Steve mentioned, been extremely acceptable service these days, with at least almost half of those clinics providing this service now. patients are much more informed. So they want to get the best possible outcomes rather than trying multiple attempts. Sometimes some patients demand all-in approach, and patients have a choice to make, and if they're denied, they would explore other avenues. Also, the age of the patients coming through has steadily been increasing for the last couple of years. So blame it on lifestyle choice, career, or professional focus. But as we all know, PGTA would help us get those patients pregnant relatively faster. So what does PGTA do? So PGTA would basically assess each embryo's chromosomal health before the transfer. So we make an informed decision of transferring by identifying of which embryo is most likely to lead a healthy pregnancy. And that helps to improve the IVF outcomes by identifying the euploid embryos. As I mentioned, the age of patients coming through has increased, and we all are aware that the rates of aneuploid increase with maternal age, affecting the chances of conception negatively. Evidence has also shown that it helps in reducing the preterm deliveries. We also are one of the largest clinics providing surrogacy for a variety of reasons. Surrogates now have a choice and prefer to proceed ahead with screened embryos in order to get the best outcomes for both the intending parents and themselves. So evidence of PGTA towards the improved outcomes with robust data supporting the procedure helps clinical staff get convinced about the process. So we had a fair bit of challenges wherein everyone had their opinions and apprehensions earlier. One of the reasons was because the HFEA, our regulatory body, has traffic light systems, which views PGS as another add-on. So the clinics in the so the colleagues in the clinic had apprehensions earlier, and as things have improved over the last couple of years on accuracy of testing and interpretation of results, opinions have swayed towards acceptance. Patient interest and inquiries on PGS have also increased, and the services need of an hour for a private clinic. PGS is a complex subject, and as you would think, the non-clinical staff members find it difficult to understand and explain to patients and can be easily misinterpreted. People expect us scientists to do miracles and create designer babies. PGS doesn't do that. We are all trying to achieve is a healthy embryo in order to get a full-term pregnancy. And that's why we said that we would offer the service to our patients who would wish to proceed ahead with it. Also, people don't want to have multiple attempts, as I said, and want to reduce the time towards pregnancy, and PGS would help achieving that. So that's why we said we would carry on with the PGS as a service for our patients, and we are in the process of applying to the HFEA. Although, as Emily mentioned, it took some time for us to reach this stage, also due to the closure of clinics due to COVID-19 and stopping the treatments, did not help towards the application. So now that we are in a much better position wherein we're offering all the services, we are back to the place wherein we are getting things ready for the application. Regards to why we've chosen Cooper Genomics is because we already have a relationship with them, and they are one of our trusted partners. So they provide us with equipments and maintenance, and the consumables required for PGS are available with Cooper. They've also had a lovely training support from Cooper. It's been extremely helpful. It's one of the most comprehensive, well-balanced course, I would say. I've been personally on that along with my colleagues. And they also offer genetic counseling. So that would help our patients who want to understand and the results better, or sometimes even for that matter, who want to embark on the PGS treatment. So that's a great help from Cooper with genetic counseling. Especially as a new clinic, we might struggle having an in-house counselor who can give genetics counseling services. This is very helpful from Cooper. So that was another reason why we chose Cooper. The lab is based in London, in Imperial, and that helps us logistically. So we get the samples shipped over in shorter time frame and get results in acceptable manner. So those were one of the reasons why we went on the train of PGS, and hopefully we'll start the service soon for our patients. So I'll now hand over to Emily again.
Thank you so much, Rahul. Thank you very much indeed. So I will invite all of the panelists to join us now. So everybody's video cameras on, everybody's mics on, and we have some questions that have come in. So I've got a couple of specific questions to start with. Claire, one's come in specifically for you, and this inquiry is, how do you work up your Pgtm cases?
So far, we actually haven't got that much experience with Pgtm. We've literally just had one case. Most of our cases are all Pgta. We followed the exact protocol as Zuza outlined earlier, in that we go through the whole procedure for the sample workup. So, you know, the initial samples are taken from the patient, the genetic diagnosis is confirmed, and then, you know, once you give us the go ahead that the probe is ready, we will go and do the PGT then. So the process is all outlined according to the Cooper Genomics protocol, and we followed that exactly.
Lovely. Thank you very much. Perhaps, Davina, you want to comment on that, because you're obviously doing Pgtm, aren't you?
Yeah, the same. Yeah, follow the protocol. Our patients see the genetics team, so the team that we've made up of a clinician, nurse, genetic counsellor and geneticist. So they enroll the patient, they have all the information about their genetic history and their family, and so they enroll the patients for us because they have all that information, and then obviously we wait for the go ahead from Cooper Genomics to say that the workup's completed before enrolling them for a cycle. But it's very easy to follow. It's a really easy process to enroll for both Pgtm and Pgta. We've never had any issues. It's very straightforward.
Oh, super, thank you. We had a question come in inquiring about the educational tool that you were describing, Claire, which is Engaged MD. Perhaps you could run through us what you find the benefits of having Engaged MD to be.
Yeah, I suppose it's really useful for us. And the way we use it in our clinic is that, well, the patient is obviously seen by the doctor first, and then the doctor, they go to see the nurse afterwards. So the nursing team set up the patient on Engaged MD. So it's a web-based program. So you input the patient's name, details, phone number, and email address, and then the patient gets sent a link to videos. So once you do that, once you set them up initially, the process is very automatic from there on, so very straightforward. The patient receives a link and they log in and they watch the videos. And then from our side on the portal, I can see how many videos they've watched, if you know, and they have to, after they watch each video, they have to answer, I think, 5 questions. And I can see if they've answered those questions correctly or not, or I can see their progress through the program. And when they have all of their videos watched and the questions answered, it will then allow me to generate the test request form, which is the first form that's required to register the patient with Cooper Genomics. So it's very useful for us as well, because a lot of us are working from home now more. So I think post-COVID, it's been even more useful, because the test request form can be completed in the Engaged MD platform, and it uses DocuSign to sign off on it. So I can sign my part. I usually fill in the background for the patient, you know, the reason that they're having PGT. And then once I sign off on my part, it automatically goes to the doctor, and the doctor signs off. And then when the doctor signs that, it comes back to me again. I get an email to say it's been signed off, and I can then forward that on to you, you know, in Cooper Genomics. So the whole process is very automated and very simple and straightforward, I think, using the Engaged MD platform.
Brilliant. Thank you very much. And we do supply Engaged MD free of charge for all of our genomics customers. Yeah, so please feel free to get in contact with us if you're interested in that. Davina, I've got quite a specific question here for you. What was the cutoff for contamination rate in your validation process?
Well, we were looking for no contamination, ideally. So it was if there was any contamination, you would continue to do validation samples. Obviously, at the moment, Cooper Genomics don't ask for blanks with their actual treatment samples. So that initial validation is just to check that your system works and it's sterile and you're not contaminating the samples when you're tubing. So it's a good test of your system initially, that you are doing it correctly and in really sterile technique, and you're not contaminating the samples. So for actual, once you've established that your system is okay and the practitioner can do that without contamination, then obviously for the clinical cases, you don't send blanks. So obviously you're relying on the fact that that training's been done and completed, and it's fine.
Brilliant. Thank you very much. Rahul, Davina, Claire, is another practical question here. As part of biopsy validation, you mentioned survival. So do you mean survival post-biopsy, or did you freeze after biopsy and thaw? Perhaps, Claire, you want to take that one first?
Yeah, I guess we looked at the two options there. The first one for the initial training was survival immediately post biopsy, so we looked for some re-expansion. But in terms of the final validation, we looked at survival after vitrification. So we did the biopsy and we vitrified within 30 minutes afterwards, you know, like as if it was going to be a real case. We vitrified as soon as we could. And then we thawed the sample and assessed the survival at that stage.
Ah, lovely, thank you. Rahul, are you that far along in the process? Would you like to comment on that one?
We haven't started the validation, but that is the plan on the SOP to as Claire mentioned, to see for the first few cases survival post biopsy, and then eventually when the final validation happens, we would vitrify those embryos and see post vitrification survival as well of the embryos.
Super, thank you. Davina, was it the same case for you, or are you doing something different?
We concentrated more on survival post-biopsy, and that the cell sample that was taken was suitable and there were enough cells taken from the embryo. So we did look for re-expansion. I think if you've got a well-established vitrification program and the survival rates are good, then freezing a biopsied sample shouldn't be any different, and the survival shouldn't be any different. We collapse our blastocysts before freezing anyway, and after biopsy they tend to collapse. So we didn't focus as much. We have done samples where we froze them and thawed them, but it wasn't part of the validation of that biopsy practitioner, because if they can freeze an embryo, then you know they're validated already to freeze. So we didn't use that.
Yeah, that's a fair point. Thank you. Tony, we've had a question come in about genetic counselling. Perhaps you could just describe for us what in terms of genetic counselling, what it is that we provide.
Sure. So in terms of genetic counselling, we have our own internal genetic counselling team, and they counsel the specific part of the process, which is the PGT process. So they don't counsel your patients about general infertility or the general risks of their diseases. That should be counselled before they come to us, but they'll counsel about the process and the results that you get. And you know, we've discussed setting up a PGT program here, and there's very different genetic counselling requirements for a Pgtm case compared to a Pgta or SR case. Pgta cases, the genetic counselling usually occurs post results if there's a query. This whole subject of mosaicism, and that's generally where genetic counselling could be of use. We also have a webinar on everything you need to know about mosaicism, which is quite a good starting point for that. As it comes to Pgtm, it's quite different, because there needs to be, the genetic counsellor is involved with actually deciding whether we can run the case, their expertise, also talking to the patient before the case for enrolment calls to make them sure they understand where they are, and quite often there's extensive genetic counselling after the event, and sometimes, frankly, that genetic counselling can go on for years afterwards, and it's a really extreme and involved process. We were talking just yesterday about a case from 2016 that was still answering genetic counselling questions. So there's a very different sort of spectrum of genetic counselling questions depending on the test, but we're here. The genetic counselling is is part of Cooper Genomic service, and we have a very extensive and experienced team of genetic counsellors.
Wonderful. Thank you very much. I come back to Davina, Claire, and Rahul. If you could pick one tip, what would be your best tip for somebody looking to embark on a PGT program? Rahul, we'll go to you first.
I would say understand the process completely. Make sure everyone's on board in the clinic, so that everyone, when they are able to offer the service, speaks the same language and the patients understand it clearly. Keep it simple and let the patients ask as much questions, understand the process, and then accept it as one of the services which they want to embark on.
That's super. And do you have any advice for getting the rest of the clinic on board? I know Claire spoke quite passionately that this is a really important thing to do.
Yeah, I think education and understanding of what PGS does. As I said, people expect from outside that what we are doing is a bit of a magic inside the lab and trying to create designer babies, but that's not what we are doing. We're trying to understand a bit more about the embryo to select the best possible embryo for the healthy pregnancy. So when we had support from Cooper, who have come to the clinic and shown us slides and explained the lectures about how things work and what would work in this scenario, and patients would benefit out of it. The clinic understands it, so the clinical and the non-clinical staff have attended those courses and understood the process a bit more. And then if they had any questions, they could ask those questions, and as a neutral party answering those questions from Cooper, they would give them a straight answer, which my colleagues have understood that this would benefit patients in the grand scheme of things. And that's why I think most of the opinions have been towards providing the service rather than before, wherein people were a bit apprehensive about it.
Yeah, brilliant. Thank you. Davina, what would be your top tip?
I think to have a strong genetics team, so you've got someone from each discipline that are dealing with the patients, so the patients have got a go-to person and they're seeing the same people, because you know the information is quite complex. I think having just one person saying it, not getting mixed messages, and also to agree a policy and who you're going to offer, particularly Pgta to, so that not all the clinicians are offering it to different people. So have a specific policy on what, you know, who we're targeting for Pgta, particularly with it being read with the HFA. It's not for everyone, but there are specific patients that, you know, that can benefit. And so I think having that policy and all agreeing to it and being on the same page is really important.
Brilliant. Yeah, clear and cohesive agreement as to who to provide it for. Yeah. Thank you. Claire, your top tip?
My top tip in terms of embarking on starting a program is to be realistic about the time frame. It's not something that can happen overnight. You know, I think we've all gone through our different experiences here, and while they're all different, I think the common theme is that it's a huge amount of work and it requires a team effort. So it's not something that you can say, oh, we'll introduce PGT, let's offer it to next month's batch of patients. You know, it's realistically, I think it's a year. I mean, I know you may do it quicker than that, but I think from start to finish, in terms of getting your SOPs, your validation, your paperwork, getting the whole team together, it's a long process. It's a rewarding process at the end because it's a huge thing to achieve for the clinic, but there is a huge amount of work involved.
Yeah, super. Thank you very much. Well, I'm conscious of time because we're slightly running over, but I've just got one very last quick question. As Claire's just said, setting up a PGT program, huge amount of work, but Davina, worth it?
Oh, definitely. Yeah, I think to be able to offer that to a select group of patients that are really going to benefit, you know, it's really good to be able to offer that to our patients.
Super. How about for you, Rahul? I know you're halfway through the process, but will it be worth it?
Absolutely. At this point of time, telling the patients that we don't offer it yet and sending them or referring them to the other clinics is not the best strategy, I would say. So yeah, absolutely worth it.
And for you, Claire?
Yeah, oh, absolutely worth it. Yeah, I mean, from the very first patients that we did, the results are just phenomenal. You know, when you get a bad result, sometimes it's a good result, you know, for patients that have had a couple of cycles and they just can't get the normal embryo. At least you can get closure, you know, and you can sometimes get an answer for patients who have never had an answer as to why things don't work, you know. So I think it's worth it for 100% from that side.
Oh, brilliant. Thank you. And thank you very much to all of our presenters and speakers today, particularly to our speakers from clinics. We greatly appreciate you giving up your time during the busy working day to join us. It's really brought the subject of how to set up a PGT programme alive, to hear your first-hand experiences. And I'm sure it's been very useful for our delegates today to pick up lots of tips and tricks as to how to set up a PGT programme.